Good morning and welcome to the Introduction to Ultrasound. My name is Giuliano De Portu. I'm an assistant professor here at the University of Florida in the Emergency Medicine Department. And we hope you have a good introduction. And if you're new to UF, welcome to the Gator Nation. I'm going to start talking about Mr. René Laennec, a French physician who came up with a device in 1816. Everybody thought he was kind of crazy, that it was not going to be around for a long time. But actually, it is. And we still use this. This is the first stethoscope. And we've been using that for 200 years. And this is Mr. René Laennec, and auscultating a kid and his very happy mother. A lot of stuff going with point of care ultrasound, medical education, and obviously in residency. This came out in the New England Journal of Medicine called point of care ultrasound, stop listening and look. So interesting. A lot of good things with ultrasound at the bedside. And since it's an introductory lecture, and I want to talk about where ultrasound came from, basically. So this is the Titanic, and you know that she sank in 1912. And after that, well, they were really concerned that they wanted to figure out if they could find a way to locate icebergs in water. So the concept of geolocation was introduced, and the first sonar, stands for sound navigation and ranging, it was used in 1914. So they were looking for icebergs. And, the military were kind of interested in, if you find, stuff in the water, maybe we can look for submarines. So a lot of the initial research on ultrasound is basically, derived from the sonars in submarines. This is probably the first clinical ultrasound that was used by Dr. Ludwig, at the naval base. A lot of, again, military research was classified. He was looking for gallstones in foreign bodies and tissues, but it was published in the 1940s. So that was probably the first clinical ultrasound. And this is from the the archive of the American Institute of Ultrasound and Medicine. They have kind of like a traveling museum when they have conferences, and they show you these old machines through the years. And the first initial images that we could obtain from ultrasound look pretty much like that, like something from a garage, not really maybe clinically significant, right? So as things progressed, that's in the 40s, by the 1960s, there were way better imaging. And Life magazine did this great piece on medical advancements in ultrasound, and you can see this lady, sitting there. This is the ultrasound right here. And she's there with kind of a big bag of fluid with those initial probes. Again, the patient is here, and kind of like those primitive or initial probes kind of sitting in the bag of fluid, kind of reminding you that it does come from the ultrasound from the submarines. This is, this round structure here, obviously, is the fetal head, okay? And this is a gentleman, also doing some, musculoskeletal ultrasound. He's sitting kind of in a tub full of water. I see all these electrical cables. I'm not sure I'd be very happy sitting there, but those are kind of the images from the origins of ultrasound. And nowadays we have machines that are, very, very small, very portable. They fit in the palm of your hand. So that's kind of cool. And even more recently, I came across this finger transducer that you can put on your finger. And you can obviously, get some pretty good images. Again, a lot of research funded by the Department of Defense. This was initially tested. You put it on your finger. You can actually slide your hands under somebody's body armor, and you can probably do a fast exam. So nowadays, ultrasound is utilized. This is from the pre-hospital setting, paramedics in Texas, and advancements obviously in anatomy teaching. We started, stealing cadavers there in the 17th century, and we're kind of, obviously this is mainstream teaching now. We have ultrasound medical school, ultrasound throughout our residency. So again, a little bit more info. If you are new to UF, go check out the Bat House. And it comes from bats because initial research, like in the 1800s, there's an Italian researcher, saw that he can blindfolded bats and they could navigate, but they would do fine. But if they would bump against obstacles when their ears were covered, and I don't really know how he like covered their ears. But that bat problem was kind of a scientific mystery until like the 1940s in Harvard, when they actually figured that the bats would emit sound waves at 100,000 hertz. They can navigate, and they're not the only ones that use ultrasound. Dolphins use it. Okay. Another concept of ultrasound is the concept of piezoelectricity. And Pierre Curie there found that when you apply some stresses, so some crystals, they create an electrical potential, mechanical stress. And so kind of an image of that, and that's how our transducer, the crystals, work. So here at the University of Florida at Shands, we're a level 1 trauma center, about 100,000 visits and trauma patients, 990 alerts. This is one of our trauma bays. And as you can see, obviously, ultrasound is an integral part of the trauma exam. It's another one of our shots in the trauma bay, and the ultrasound there in the left lower corner. So when we talk about ultrasound, we have to talk about physics, and I know that's probably how you feel when you hear the word physics. But ultrasound works with sound waves, and sound waves, this is a mechanical wave. All waves carry energy from one location to another. And for you sci-fi fans out there, this is from the movie Alien, and this was actually their kind of advertising campaign. In space, no one can hear you scream. So yeah, sound is a mechanical wave. It cannot travel in a vacuum, so it needs a medium to propagate, and that concept is called medium disturbance. Waves again have wavelengths, frequencies, and another fun fact for you to like consider is that in dry air the speed of sound is about 343 meters per second, but it travels about 4 times faster in water. And that's because I just told you that sound needs a medium to propagate, and water being more dense, if you think about it, it's a liquid, it's denser than air. In a way, the molecules are packed tighter in water than air, so it propagates faster through that water. This is another cool picture of an F-18 with that cone when it breaks the sound barrier. And what happens when you break the sound barrier actually is not that the sound that you hear, the sonic boom, it's not when they're breaking the barrier. It's just a summation. If you see this red dot, that's kind of the plane traveling faster than sound, and you see the sound waves traveling behind the plane. So what you hear is a summation of all the sound waves, and the boom that you hear is when that summation of the waves actually kind of hits your ear. The plane and the sound waves are at the level of your ear, and you hear that boom. Okay. Sound waves are measured in hertz. Audible sound is about 20 hertz to 20,000 hertz. And ultrasound waves are not heard by the human ear because they're greater than 20,000 hertz. Clinical ultrasound ranges from 2 to 20 megahertz, millions of hertz. Okay? And the principle behind our transducer is based on the pulse echo principle. So you have a transducer here. It's sending a signal, it's propagating there to the right, and it travels a distance, it hits an object, and it kind of listens for that reflected wave when it comes back. And then it plots that returning echo with the intensity of reflection and the depth of that item. So we need to talk a little bit about terminology. You're going to hear us use these terms all throughout the rest of your life, basically. And when you're talking about echogenicity, you talk about hyperechoic structures, and this is a structure that we're looking at. And if you compare that structure in relation to the other structures around it, so this has hyper echoes or greater echoes. Hyperechoic, just like anything in medicine, hyper is higher, so higher echoes. Hyperechoic. Then we have hypoechoic. You see, again, this structure here in relation to all the other structures has less echoes, hypoechoic. Or you can have structures that actually have no echoes, or anechoic, no echoes here in comparison to the other ones. So here's a all three lined up together: hypoechoic, hyperechoic, and anechoic. Okay. Another concept is that structures, obviously, like in radiology, they have different ways of reacting in a way to like X-rays, ultrasounds. So you will see structures with highest amplitude or brightness are going to be bones, calcifications, and then as you go down this list, they have lowest amplitudes. So they either the echogenicity changes. So you have bone calcifications, and you have fascia, like diaphragm, pericardium, soft tissues, liver, organs, and then fluid, blood, urine, bile. That has the lowest amplitude, and they're probably going to show up as blood shows obviously as anechoic. So does urine. Another thing that occurs with ultrasound is that you have image artifacts, and that's just because of the physics of the machine. But some artifacts are really important for you to kind of know. One very common one is shadowing. It's probably one of the most common, and it occurs when a beam encounters a highly reflective surface with a high attenuation, and that energy from the beam is returned, with little left to continue. So it creates a shadow. So basically, your transducer is up here, and that's kind of it's going to be basic for every ultrasound that you do. Doesn't matter if it's a peripheral line, a gallbladder. So your transducer is up here. So the sound waves, start to propagate downward. And as they go down, they find different structures. This is the gallbladder. So there's a little bit of you see this border is hyperechoic. This is a hyperechoic structure, right? This is kind of like hypoechoic, maybe even anechoic, although it has some, some echoes there. So what happens is the waves hit this highly reflective structure, and basically there's not a lot of energy, so it doesn't propagate as much. So you have this shadow, and that's very, very classic and very important for you to consider. Another one is called an edge shadow. Okay, so again, your probe is up here, you're scanning, and the beam, the ultrasound waves are going down, and basically these lines here, it's called the edge shadow. It occurs because there's a change in direction of the sound beam as it hits a curved structure. Okay, so there's a concept that waves are scattered and refracted, and it basically can occur in any cystic structure. And it's kind of they lose the energy on the lateral edge. Okay. The next one is acoustic enhancement, also very important for us. So again, our beam is coming up here, up here, up here, here continues. Then what happens is that the waves have encountered a structure that has less attenuation, and basically there's like more energy left on the beam. So when the waves propagate and they come down here, there's kind of like this hyper echogenicity there, and that's the acoustic enhancement. And why is that important? Because when you're measuring, for example, the gallbladder wall, and you'll listen to a dedicated gallbladder and GI lecture, you want to measure let's say the anterior wall, because this artifact could create a false positive. Obviously, this is not a gallbladder, this is a globe, but it's just the same concept. Okay. Gas is not our friend. Obviously, ultrasound propagates through air, but for clinical ultrasound, it creates an artifact. And this is kind of the same picture from earlier when you had that edge shadow artifact. And this is just probably gas from the bowel. And obviously here you can see structures. Here you have that artifact created by the gas. Okay. Another one is called reverberation, and that occurs when your beam, again up here, is starting to pass through structures that are highly reflective. And so when they hit a highly reflective structure, it kind of starts to have kind of a bouncing effect, if you would say. And they start to create lines that are equidistant from that original line. And that occurs in the bladder, for example. That's reverberation right there. And it occurs with lung ultrasound when you have that, you probably have the pleural line, and then you have equidistant lines reverberation. In lung, these are called A lines, but more of lung ultrasound later. Another important one is you have mirroring artifact, and mirroring occurs when you have structures that are on both sides of a strong reflector. This is a diaphragm. So again, waves are coming from up here, go down, go down. You have a highly reflective structure, and then you have multiple reflections along that line. So basically the machine gives you an incorrect interpretation of the signal. So you have the liver here, you have the kidney here, and then you have the diaphragm. Okay, so you have liver. You obviously don't have liver in your chest, but that's mirroring. And it's great because the absence of some of these artifacts will indicate pathology. A little bit more of that again later. Another concept that's kind of really important is one that we're going to show here. Is a drawing courtesy of my dad, who's a retired architect. So we have our scanner here. I'm sorry, our ultrasound probe. And if you need to measure, when you're measuring a cylindrical object, such as the aorta, the IVC, you need to be kind of like really, really centered, okay? Because if you're off axis, basically, you're gonna have a problem. And I'll show you why that's important. If you're measuring, an aorta, you don't want to call it non-aneurysmal if it's really aneurysmal, right? So this is called cylinder tangent error. Basically, again, this is a drawing. When you're placing your probe, if you're like off center here and you measure along this plane versus if you're kind of smack in the center where you should be, you're going to have different measurements. And that is very, very important for you to consider because it could be really problematic, again, if you miss a AAA. A little bit of humor there, like some of my patients that they think they need antibiotics for everything. So let's move on to settings and planes. Every transducer has an indicator. They're like that. Some of them are different, but basically that correlates with a screen, and that's your indicator, image indicator. So you can orient yourself when you're doing your ultrasound. Basically, that ultrasound transducer, you can look at the body in basically anatomical planes, just as the same anatomical planes in anatomy: sagittal, transverse, and coronal. And this is an example, for example, of a sagittal plane. And when you have the indicators pointing towards the head, okay, there's your indicator right here, image indicator here. So then that tells me when I'm looking at the image that the head is here on the left side of the screen, and the feet are going to be here. And this is this is going to be the head, like I said, feet, anterior and posterior. Okay, if I rotate my probe from that initial sagittal view, and now my indicator is pointing towards the patient's right, I'm gonna have like a transverse type of plane, kind of like the ones that when you look at a CT scan, you probably are familiar with those. So it's gonna be right of the patient, again, indicator pointing to the right, so right of the patient, left, anterior, and posterior for your transverse view. And then we're doing a fast exam. We're now on the right upper quadrant along the mid-axillary line. You have the indicator towards the head, so that gives you a coronal plane. So you're gonna be, remember, up here is where your probe is touching. So if I'm touching here on the side, this is gonna be, if you want to take a guess, the head is always up, indicator. This is going to be lateral, okay, to medial. That make any sense? So let's continue with a little bit of knobology. And knobology is the functionality of controls on an instrument as relevant to their application. That big, fancy word here. So if you're going to take only one thing from this lecture, and I do hope that you take, a lot of other things, is that this is the button that turns the machine on. So on button, very important, that you're going to have some other controls, and they're equally available in any machine. Any ultrasound machine, regardless of the brand, should have controls for gain, depth, depth you see there. You have M mode, Doppler, color, 2D, and obviously you have different probes, transducers with different frequencies. You have a different footprints also, and this area there, this is where all the magic happens. Okay, and they're very, very fragile, so handle with care. Don't run over them with a machine. Don't like let them drop on the floor. To get an idea, they're about $15,000 each. Okay, so we'll just go ahead and take that from your paycheck if you break anything, and obviously kidding. So basically, several modes here in ultrasound. You have A mode, B, M, and D. A stands for amplitude. You remember those pictures, those images, those early images from the 1940s, kind of the, they had some amplitude, not a lot of imaging. So that's A mode. B mode stands for brightness, M for motion, and D's just a B, bidimensional one. So B, brightness, basically the one that we always see. M mode shows motion. And what happens if when you click on your M mode, you're going to have a line that comes down, and you can move that line here anywhere in your anatomy. Here we're looking at the mitral valve. This is a echocardiogram. So what happens if we place our M mode here, and then you're kind of like cutting through that space in anatomy. What happens is that same space is here, and what the machine plots is basically that anatomical structure in a plot of time. So you'll see structures that are moving. In this case, you see the mitral valve closing and opening, closing, and you can do that for other structures, right? You have Doppler, where you're able to see blood flow. Red and blue is not arterial and venous. We'll talk about that later, but it does show flow. This is another power Doppler. When you see, actually, this is the bladder, and you're seeing actually where they're called urethral jets, and you actually see urine flowing into the bladder. So, pretty cool. You want to be able to optimize, the depth of what you're looking at. And this is kind of an example. This is a right upper quadrant. When you have liver and kidney here, but you have a lot of like not very useful images down here. So what you do is you control and on the right side of your screen, I'm sorry, that it tells you how deep you are in centimeters. So that's probably too deep. So you want to control the depth and decrease until you kind of optimize your image. So you're now from 20 to 12. So that's, again, that's very, very deep. That's down to 35 centimeters. So you just want to you're too deep. That's pretty more optimal of a view. So too deep, adequate. And for all of us who remember black and white TV, all those 50 shades of gray scale there, basically you have the gain. And the gain, you have it on the left side of the screen if you're using the M Turbo, and you have near field and far field. And basically the gain is the way of the machine interpreting the echoes. So you can be over gained, on this side, maybe a little bit too bright, versus adequate gain when you do see proper images. So again, gain is changing the overall strength of those returning echoes. Okay, so it kind of helps you amplify if you need to. So this kind of looks maybe okay, the near field versus the far field. So near field and far field probably a little bit under gain there in the far field, okay, versus like the near field here, it's under gain, and near field under gain. This is maybe a little bit better. And applications of ultrasound, we will continue to give you lectures, but we basically are able to visualize, from eyeballs all the way down to the ankles. We do fast, cardiac, ocular, MSK, OB, renal, procedures, and obviously fast exam and GI. So thank you. We hope you have a good time, and it was a short introduction to ultrasound. And don't forget to watch the other videos. Thank you.